I'd like to introduce first speaker. First speaker is Kwon-Ju Lee. He graduated from National University and currently his position of Department of Urology and Seoul National University. And please, Dr. Lee, carotid dissection treatment.
Good afternoon, everyone. I'm Kwon-Ju Lee from Seoul National University Bundang Hospital, South Korea. In this debate session, I'll make a short talk about medical treatment for patients with cervical artery dissection. First, I'll show you two cases who admit to our center. The first case was a young woman who came with a visual problem in her left eye. She was diagnosed with left branch retinal artery occlusion. You can see a tight stenosis on her left proximal cervical artery with a minimal perfusion delay. In the conventional angiogram, more than 90% degree stenosis was found, and high-resolution MRI confirmed an artery dissection with intramural hematoma. At discharge, this patient had no further symptoms, and we used only aspirin with low-intensity statin. After 6 months, you can see that the stenosis disappeared and all the intramural hematoma was resolved. So we quit aspirin and she is fine without any medication. The second case was a middle-aged man who came to our ER complaining headache and left eye blindness. There was some embolic infarction in the left middle cerebral artery territory, and there was almost no blood flow from the proximal carotid artery with moderate degree perfusion delay. In the conventional angiogram, we can see a diffuse narrowing, especially up to the petrous segment of the ICA, so-called the string sign. Our interventionist inserted a stent along to the long segment dissection. After 3 days, we can see the lumen is widened and intact. The patient discharged with no symptom. His visual symptom recovered fully under prescription of dual antiplatelet agents. So we saw two happy cases. The first case used only a single antiplatelet agent, and the second case underwent endovascular therapy, and both cases ended well. There might be 3 treatment options for cervical artery dissection. First, medical, second, endovascular, and third, surgical therapy. As today, I'm on the side for medical treatment. I'll focus on why medical treatment should be the primary option for cervical artery dissection. Year 2014 AHA-ASI guideline recommended the management of cervical artery dissection as following. First, those who experienced ischemic stroke or TIA are recommended to use either antiplatelet agent or anticoagulants for 3 to 6 months. For those who have stroke recurrence despite medical therapy, they are recommended for endovascular therapy, and if both treatments are failed, then the last option would be the surgical therapy. Besides these recommendations, there will be some points to be considered for choosing the treatment option. First, how much is it dangerous, which means what will be the risk of stroke recurrence, especially when will be the risk is most highest, which is very important to decide the treatment duration. And then, which strategy can we use for medical treatment? There will be 2 options, antiplatelet or anticoagulation. There are many studies which show the risk of stroke recurrence after cervical artery dissection. These studies were heterogeneous in sample size and follow-up duration. Also, the recurrence rate varied from 0% to 13%. However, it should be noted that the study which showed the highest event rate included event before study enrollment. So the event rate after enrollment was 5.8%. There were more recent studies with larger sample size. This study reported stroke occurrence in cervical artery dissection without ischemic stroke or TIA. The event rate was very low, 1.25% in the first 2 weeks, and then lesser than 1% after then. And after 1 year, there were no stroke events. In those who experienced stroke events, a multicenter cohort study of French patients was the largest study. However, the event rate was also very low. 12 events in 459 patients, which is about 2.6%. All events occurred within the first 2 months. In the CRCSK database, which is a multicenter cohort of stroke patients in South Korea, we were able to find more than 400 patients. More than 97% underwent medical therapy only. There were 15 stroke recurrence events. About half occurred within the first week after stroke onset, and there were no event after 6 months. By these data, we can tell that stroke risk after cervical artery dissection is generally low, and occurs mostly during the early period, which can tell the recommendation for antithrombotics for 3 to 6 months after dissection is plausible. So which is better, antiplatelet agents or anticoagulation? The famous CADIS trial results can't give you an answer. This phase 2 trial concluded that the event rate after cervical artery dissection was very low, especially after 3 months. And there were no differences between antiplatelet therapy and anticoagulation. It also concluded that a phase 3 trial will need about more than 10,000 patients, so getting the answer for which treatment is better will not be possible and may be unnecessary. This result was also reproduced in the non-randomized arm of the Carotid trial and the meta-analysis of other 39 observational studies. The efficacy of the two treatment strategies were equivalent. So even the results of the CADIS trial suggest the efficacy of antiplatelet and anticoagulation is not different. Will there be an area for anticoagulation which is more stronger therapy but has much higher bleeding risk? There was one recent study from the Chinese investigators which used high-resolution MR findings in cervical artery dissection patients, showed two image parameters which were irregular surface of the vessel and intraluminal thrombus were associated with stroke occurrence. So the patients with specific image findings might benefit for more intensive therapy such as anticoagulation or dual antiplatelet agents, as they might have more higher risk of stroke occurrence. Besides, as I showed you in the beginning of my talk, I would like to share an idea that perfusion images might have a utility for selecting patients who have a high risk of neurological deterioration and be a candidate for endovascular therapy. There are only some case reports for this subject. In conclusion, cervical artery dissection patients have generally low risk of stroke recurrence, so most of the patients would have good outcome with only medical therapy. The CADIS trial results showed antiplatelet and anticoagulation therapy were equivalent. However, there might be some portion of patients who will benefit from more aggressive treatment, such as endovascular therapy or anticoagulation. And image studies, such as perfusion images and high-resolution MRI, would give us some clue for decision making. This is the end of my talk, and I'm looking forward to Professor Zhang's talk and the discussion. Thank you for your attention.
Dr. Lee, and I would like to introduce the next speaker, Junyang Zhang. He